Hello, everyone, and welcome to our webinar, Domestic Violence in Later Life, Detecting and Preventing Homicide, Suicide, and Understanding the Possibilities for Intervention. My name is Sheila Schuline, and I'm one of the Elder Abuse Ontario organizers for today's session. I'd like to thank you for joining us and review a few housekeeping points before we get started. So the next slide, please. So you folks are all muted during the webinar, and if you have any issues, please type your questions or your concerns into the text box. And if you have any questions, as you type them in at any time, we will be leaving the last 20 minutes of the session to answer questions. And we're also going to be asking you to fill out an evaluation form once the session has ended. It will be emailed to you. Please fill out the form, as your feedback will guide us for future webinars. It's very important for us to gather your feedback. I'm now going to turn it over to one of our project collaborators, Linda Baker, who is a learning director for the Centre for Research and Education on Violence Against Women and Children at Western University in London.
Thank you, Sheila. I'm absolutely delighted to be part of this important webinar on domestic violence in later life. And just so that everyone joining us knows, this webinar continues the collaboration between our host, Elder Abuse Ontario, and the Centre for the Study of Social and Legal Responses to Violence at the University of Guelph, and ourselves, the Learning Network at the Centre for Research and Education on Violence Against Women and Children here at Western University. Part of our mandate is to identify emerging issues and gaps in knowledge or gaps in knowledge dissemination. And as a result, we came together with Elder Abuse Ontario and Dr. Dawson's Centre in 2017 to produce a Learning Network issue-based newsletter titled Femicide of Women Who Are Older. And that's what you see on your screen now. And the link that's shown will take you right to that newsletter and also other resources on our website, one that's been co-authored by Dr. Myrna Dawson and Daniel Sutton, and other grey literature that has been produced in Ontario and Canada. And I know that you're going to hear from Sheila towards the end of the webinar about some other really important resources. Now it is my pleasure to introduce today's presenter, Dr. Myrna Dawson. Dr. Dawson is one of the world's leading researchers on femicide. She is a professor at the University of Guelph, where she is the Canada Research Chair in Public Policy in Criminal Justice and the Director of the Centre for the Study of Social and Legal Responses to Violence. She is also co-director of the Canadian Domestic Homicide Prevention Initiative with Vulnerable Populations. Recently, Dr. Dawson launched the Canadian Femicide Observatory for Justice and Accountability. And if you haven't had a chance to learn more about that or to follow it, please do, because we're all very excited with what that observatory can do for Canada and for women's safety. Her most recent projects examine the role of gender, and intimacy in legal responses to violence and content and uptake of recommendations from domestic violence death review committees in the international context, and has recently published a book on this topic, and its title is Domestic Homicides and Death Reviews, an International Perspective. Not surprisingly, Dr. Dawson serves on the Ontario Domestic Violence Death Review Committee. So with that, I'm going to hand over the mic to Myrna.
Thank you very much, Linda. And thank you to Elder Abuse Ontario and the Learning Network for giving me the opportunity to discuss the issue of intimate partner homicide and suicide among elder couples. The need to ensure the quality of later life for women and men, and elder abuse in particular, is gaining much attention, as I think most of you know, not only as the population ages, including ourselves, but as many of us deal with our own loved ones who are in their later years. We all hope never to deal with lethal violence in later life, but if we do, awareness and education will help prevent against that in our lives and in others' lives. So to begin to discuss some of the learning objectives today, we have 6 in total that we're going to get through in the next bit. The first 3 learning objectives examining common risk factors for lethal violence among elder couples and how they differ from younger couples, I will draw from two types of data. The first is longitudinal data that I've been collecting for the past 2 decades that documents all homicides in Ontario for the past 40 years. While these data were not originally collected with this population in mind, we're able to use these data to provide the broader context in which intimate partner homicide and intimate partner homicide suicide occurs among elder and younger couples. Focusing in detail on more recent trends, I will use data from reviews conducted by Ontario's Domestic Violence Death Review Committee. The next 2 objectives, we will draw in more detail from the death review data using case studies to highlight the importance of some of the recommendations that have been made to date, drawing from some of these cases that are intimate partner homicides or intimate partner homicide suicides involving elder couples. This will underscore what we have learned so far through these reviews and what knowledge gaps remain. Before moving on, though, just some notes about terminology. There's actually little consensus in the research or in public opinion about what should be classified as later life or what terms should be used, and often this depends on where we are in that chronology of life. For example, various age thresholds have been used to denote later life, such as 50, 55, 60, 65. A recent report on femicide by the United Nations used 55 and older, compared to the World Health Organization that uses 60 and older, and so on. In addition, we also have varying terms that have been used: older, elder, elderly, senior, senior citizen, young old, old, etc. For our presentation today, I'm keeping in line with the Canadian provincial, territorial, and national associations. I will use the term elder and define the elder group as 65 and older. And the presentation itself will focus on couples who are both 65 and older in examining intimate partner homicide and intimate partner homicide suicide. I think it's important to keep in mind, though, that those of similar ages are often very different in characteristics, so this age group, or any age group for that matter, is not homogeneous. And there are some difference in risk factors when examining homicide and homicide suicide among the elder group, depending on the threshold you use. The bottom line is, though, that differences are minimal and common risk factors remain consistent. Regardless of how elder is defined, the growing proportion and increasing lifespan of the aging baby boomers in North America warrants additional focus, as those at risk of elder abuse are increasing. In fact, for the first time in census history, elders 65 and older in our country outnumber, albeit only slightly, children under 14 in Canada, because the elder population experienced its greatest increase since Confederation. In 2016, there were 5.9 million individuals aged 65 and older, compared to 5.8 million children aged 14 and younger. Again, minimal differences, but showing that the gap is changing. It's interesting to note too, and this will come up again later, that the ratio of women to men also increases with age. For example, there are twice as many women over 85 as men. And again, this is an issue that I'll come back to. Because of this, there are increasing concerns about their unique vulnerabilities and their risk of violent victimization. And I'll pick up how, when we're examining sexual assault among older adults, or any sort of victimization of older adults, it requires an ecological, gendered, and intersectional lens. So what are some of the challenges, though? Last October, the 8th annual Milestone Global Campaign for Violence Prevention meeting was held in Ottawa, and the World Health Organization stated that elder abuse was the least examined type of abuse and violence worldwide. In fact, compared to other groups or other victims or perpetrators at risk of violence, the research was almost non-existent. And there are many reasons why this might be the case. The first is that research has often been divided by age, where young families were more the focus of family and domestic violence, elder victims were more the focus of elder abuse research, and sexual violence focused more on violence against women more generally, and not typically among couples or among older women particularly. We also have the issue that homicide is a relatively rare event, which poses a greater challenge when focused on narrowing down on particular subtypes of homicide, such as intimate partner homicide or intimate partner homicide suicide, and then drilling down once again into particular age groups. By the time you do that, you're dealing with very small numbers, which makes research more of a challenge as well. We also have social or cultural factors that contribute to difficulty identifying or detecting some of these cases. We have ageism, patriarchal culture, conservative attitudes, which are actually more common among older generations, and that may change. Issues around privacy or concerns about privacy, as well as social isolation. There's also difficulty in identifying homicides due to elder neglect, because it's difficult to understand where neglect has crossed over into what we would call homicide. Nursing home and care facilities have underreported elder abuse and homicide. And then finally, again, as I've already touched on, variations in age definitions often prevents an accurate picture. Keeping these challenges in mind, it's still important to examine elder abuse and all violence using frameworks that recognize the complexity of violence when it occurs, as well as the varying risks for victimization and perpetration. And these complexities actually increase when you're focusing on elder populations. So some of the frameworks that I use in my research, there's three actually that I try to bring in with a particular lens when we're looking at violent crime and in particular lethal violence. And the first is the ecological framework. Drawing from the public health approach, the ecological framework recognizes that no single factor can explain violence. Rather, it is the interaction of many factors at various levels. And here we see that these levels can be individual, relationship, community, or societal, that will contribute to rates or risk of perpetration and victimization of violence. And again, these are, there's blurred lines between these different levels. Individual and relationship often overlap, as do community and societal, but it's important to recognize that there's risk factors at each of these levels. Second, since women have a longer life expectancy than men, the aging population is predominantly a female one. And as I mentioned, when you reach age 85, there's double the women compared to men. And therefore, it's recognized that a gendered analysis is also crucial. So for example, compared to elder men, elder women are more likely to live longer and live longer in poverty, to rely on social welfare, to suffer chronic health conditions, disabilities, and other limitations in the activities of their daily living. And this all increases their risk of victimization and possibly death. In short, their increased marginalization as older adult females increases their risk of abuse and neglect, while at the same time limiting their access to much needed services and supports. And this is particularly relevant, as we'll see when you look at intimate partner homicide and intimate partner homicide suicide. The third framework is an intersectional analysis, or an intersectional framework, which helps us understand that the impact of one's gender, which is seen historically and still often today as our most dominant identity, and our experiences that relate to that identity, including victimization, are often significantly affected by other equally important social identities, such as age, which is the key one in the context of today's talk, but also by race, ethnicity, indigenous status, class, sexual orientation, ability or disability, and so on. So it is now recognized that a comprehensive understanding of the experiences with and the risks of violent perpetration or victimization is not possible without using these frameworks as a guide. So just keep those in mind as we proceed through some of the findings that I'll highlight throughout the rest of the presentation. So just to give you some broader context when we talk about lethal violence in later life, there is a minimal amount of research that's been done on this with varying levels in different countries, but the existing research, which is also known as elder homicide or as eldercide, has found that the rates vary from 1% to 11% of all homicides. When we look at women and men, however, we see that elder homicide often has different contexts for each gender. For women, it's more often perpetrated by an intimate partner or a family member, often the sons. More often occurs in the context of domestic violence or homicide-suicide. In contrast with men, it's more often perpetrated by stranger or acquaintances, and the contexts vary from robbery to general altercations, but also occur within the family context, but with much more variation than with elder abuse involving women. For both, however, when women or men are victims of violence, they're more likely to die after an assault. So again, few studies have examined risk factors between younger and elder couples. Often they either focus on younger or elder. And then when researchers have tried to distinguish between high and low risk of lethality in intimate partner violence, there's been a rare focus on intimate partner violence in later life. And that's the gap that we're trying to address today. So So looking at the broader context in Ontario, which is where the longitudinal data that we've been collecting have come from, we span the years 1985 to 2012. And so I'm just going to give you some of the broader picture before we narrow down into the groups that we're looking at more narrowly today. So during the period 1985 to 2012, there were almost 4,000 homicides documented, of which intimate partner homicide comprised about 1/4. Consistent with national trends, 87% of the cases involved female victims and male accused, underscoring again the importance of a gendered analysis when examining this phenomenon. When looking at all homicides, 10% ended with the suicide of the perpetrator, compared to about 1/4 of the cases when you look at intimate partner homicide only. So to put that another way, intimate partner homicide cases are about 2.5 times more likely to end in the suicide of the perpetrator. When looking at the perpetrator themselves, we see that it's almost exclusively a male phenomenon. 93% of the perpetrators are male in intimate partner homicide cases, and then 98% in intimate partner homicide suicides. Finally, we often hear of more than the intimate partner being killed in these cases, and these are often referred to using the term familicide, which is when the primary victim is killed along with other victims, which are often family members and typically children. When multiple victims are killed in 15% of intimate partner homicide suicides, but these primarily occur in cases followed by the perpetrator's suicide. As we can see from the slide there, 70% of intimate partner homicide suicides involve multiple victims compared to 30% of intimate partner homicides only. But we do see, looking at the proportion of male perpetration in all these events, that intimate partner homicide almost exclusively is committed by male, and when multiple victims, again, the number increases, and when it's intimate partner homicide suicide, whether with single victims or multiple victims, males are primarily the perpetrators. And as we move into some of the more smaller subgroups, we'll start to focus on just the female victim cases because there just isn't enough male victim cases to do a comparison. So what about age? So I'm just bringing the age factor into this broader context of intimate partner homicide and intimate partner homicide suicide. We see that as we move from the all homicide category to intimate partner homicide, and then over to the right-hand side, intimate partner homicide suicide, that the average age of both the victims and the perpetrators increases as we go across the three categories. Average age of 35 for homicides, up to 42 average age for intimate partner homicide suicide for victims. Again, 33, 41, and 45 for the average age of a perpetrator. So we see that as we move from homicide to intimate partner homicide suicide, it becomes an increasingly more elderly dominant event. So I just show here in the second part of the slide the proportion of intimate partner homicide and intimate partner homicide suicides and the various age thresholds. And as we would expect, as you move the threshold up higher from 50 to 65, the proportion that's in those categories becomes less because you're dealing with fewer cases. But you can see that in comparing the intimate partner homicide to the intimate partner homicide suicide, you see also the proportion of female victims. So this again underscores the reality that these are really intimate partner femicides for the most part, particularly when it's followed by the suicide of the perpetrator. And we'll see a bit more of that in a moment. So I want to just lay the foundation of the comparison. So we're detecting domestic violence in later life and looking at homicide and homicide-suicide. But when we're thinking about elder and younger age groups, it's important to sort of understand more broadly what are the differences between intimate partner homicide and intimate partner homicide-suicide at the more general level before we start comparing age groups. Now keep in mind as we're going through this that again, it's really the killings of women that are driving these findings because they're the larger subgroup of victims, but we'll come back to that in a moment. So as we see here, in contrast to intimate partner homicide suicides are more likely to involve female victims and male perpetrators, elder victims and perpetrators, legally married couples, couples with children, couples who were both out of the labor force, shooting as a cause of death, and jealousy or spurned lover or rejection as a motive. In contrast to intimate partner homicide, the ones in which the perpetrator commits suicide following are less likely to involve couples who are using substances, who had prior criminal records, less likely to involve the sexual assault of the victim, and less likely to involve the perpetrator's efforts to conceal the crime. So again, that's the difference between intimate partner homicide and intimate partner homicide suicide. When we move to a comparison then of the first category, intimate partner homicides that do not follow with the perpetrator suicide, and compare elder and younger couples, we see some differences that were between the homicides with no suicide that still play out in the elder and younger group. So in contrast to younger couples, looking at intimate partner homicide only, elder couples were more likely to be legally married, out of the labor force, to involve mental illness on the part of the perpetrator, and to occur in a private rather than a public location. Looking at what was less likely to be evident in the elder couple intimate partner homicides, less likely to be estranged or separated relationships, less likely to involve jealousy as a motive, less likely to involve substance abuse by the perpetrator or the victim, less likely to involve perpetrators with prior criminal records, to result in a conviction of murder, and less likely to result in shorter sentences. So all these findings hold true again when examining intimate femicides only, which include only female victims, again, because predominantly that's the largest category of victims in these cases. So then when we look at the smaller proportion of intimate partner femicide suicides, and here we're just going to focus on female victims because they are I think there was only 4 cases involving male victims, and so there wasn't enough for a comparison. So looking at intimate partner femicide suicides, we see that in contrast to younger couples, elder couples are again more likely to be legally married, out of the labor force, and to involve mental illness on part of the perpetrator. And then less likely to involve estrangement, separation, jealousy as a motive, and known prior threats against the victim by the perpetrator. Now, in some sense, some of these differences, being legally married, perhaps being out of the labor force, are characteristics of the stage in that couple's life, given that they're out of the labor force usually due to retirement, etc. So some of the characteristics of these killings that differ are because of their life stage, but some of them aren't. If you look at potentially mental illness, but drilling down to see what that mental illness would be may explain that. Known prior threats against the victim by the perpetrator, not necessarily a result of a life course stage. So there was a lot of comparisons there. So I just want to summarize sort of what were the key differences. So when we're looking at intimate partner homicide and intimate partner homicide suicide among elder couples, we see that the more common risk factors in both types of cases are the legal marriage and the out of the labor force and the perpetrator mental illness. And here, primarily, we're talking about depression. Less common risk factors in both types of cases, intimate partner homicide and then also the ones followed by the perpetrator suicide, less likely to involve estrangement and separated couples, less likely to involve jealousy as a motive. Distinct to intimate partner homicide only, we see in contrast to younger couples that elder couples, the crimes are more likely to occur in private rather than a public location, less likely to involve substance abuse by the perpetrator, less likely to involve perpetrators with prior criminal records. And indeed, that's the same with victims, less likely to involve substance abuse by victims as well as victim criminal records. And then distinct to intimate partner homicide suicide, elder couples are less likely than younger couples to have a known prior threats against the victim by the perpetrator. So we see that there's common risk factors between the two types of cases, depending on the age group. And then we see that there's a few distinct risk factors that we're going to come back to as we proceed through the presentation. So what I want to do now, most of you are familiar with the Ontario Domestic Violence Death Review Committee, which has been reviewing domestic homicide cases since about 2003. And the goal here is to investigate these cases to see where there could be opportunities for prevention of future such deaths. And so I want to draw from this data to drill down a little bit further into the more recent trends and focus a bit more on the risk factors that we've found, because this data was specific to domestic homicides, which the longitudinal data wasn't, although we have a lot of data as well. But here we were more focused on the risk factors, and I think that's important in understanding detection and prevention. So if you look here, we see the average number of risk factors. So we have a risk factor checklist, which has been circulated out to everyone, and you can access it now if you like. It should be accessible from your screen. And this is the risk factor checklist that's used by the Death Review Committee, and it's included in the back of all reports, and it includes about 40 plus risk factors that are common in the literature and that have been commonly shown to occur in domestic homicides internationally. And so we use this checklist when we're reviewing cases. And so at the end of each case review, we calculate the number of risk factors that occurred in each case. And here it's important to note that risk factors don't occur in isolation. They often cluster together. So you have a multitude of risk factors in some cases you have less risk factors. And here, if you look at the first sort of cluster of information on the slide, focusing on intimate partner homicides, the average number of risk factors in these cases was 11. So there was typically, on average, 11 risk factors in cases involving intimate partner homicide, and that's including those cases, all those cases reviewed for the past decade plus. When you look at younger couples, which again is 64 and younger, which would be the larger group, they also had an average number of risk factors at 11, compared to elder couples, which again is a smaller number, but showing much fewer risk factors, 5 risk factors. When you move to intimate femicide suicide, which are the cases that are the perpetrator commits suicide afterwards, you see that there's a slight reduction in the risk factors, 8.5 on average, 9 risk factors for younger couples. And then if you look at elder couples, you see that there's only 3.5 on average risk factors for cases of intimate femicide suicide involving elder couples. And we'll see that this plays out in some of the case studies that we'll look at in a moment. So the takeaway from this is that there's significantly fewer risk factors present in cases involving elder couples, which makes detection and prevention more difficult, although not impossible. So what I want to do at this point is just run through a bit of a comparison of the overall risk factors on the left-hand side of your screen that shows the ranking of risk factors for all of the homicides reviewed compared to the risk factors and the ranking for elder domestic homicides. And you'll see at the bottom of the screen in highlight, the ones that are listed on the left side were present in over 30% of the cases, and then for the elder couples, the ones listed were present in over 20% of the cases. And as you can see, there's a bit of variation with respect to what risk factors are here. And I think I want to draw 2 in, or identify 2. So actual and pending separation, we can see, has been commonly discussed as a very significant risk factor for domestic homicides. But if you look on the right-hand side of the screen, you can see that it is not a risk factor for the homicide cases involving elder couples. And then we can see that domestic violence history is present in 23% of the cases involving elder couples. But if we look at the general population of cases, we can see that it's present in 73% of the cases. So here, the top 2 risk factors that we normally talk about with respect to domestic homicides involving all age groups play a very different role in those involving elder couples. So when you compare the risk factors in the death review data, the only risk factor that actually is significantly more common in cases involving elder couples compared to younger couples is depression. And we'll see that in the cases that we'll look at in a moment. But here, this is broken down into two sort of factors: perpetrator depression, professional diagnosis, present in 62% of the elder couples compared to only 25% of the younger couples. And then perpetrator depression, a smaller gap, but still more often present in the elder couples. While not more common in the elder abuse cases, I do want to identify them as representing a high proportion of cases in which these risk factors were present, and we'll come back to that later. But prior threats to commit suicide were quite common, even more than 1/4 of the cases. Escalation of violence by the perpetrator was also common, although compared to the general population, it wasn't as common. And then misogynistic attitudes held by the perpetrator. And these are attitudes that reflect a belief about women as that are negative attitudes and stereotypes about women and women's role in society. So these were present in 25% of the cases involving elder couples as well, compared to only 32% in the general population. So I presented a lot of numbers, and so what I want to do now is move to 4 case studies that I'll go through fairly quickly, but not too quickly, to make sure we get a sense of what they are. And then after each case study, I'll talk about the recommendations that were derived from the case reviews and the rationale for those recommendations. So the first case example involves a homicide-suicide of an 88-year-old victim by her 88-year-old husband, who was the perpetrator. They had been married for 62 years. They had immigrated to Germany, immigrated from Germany many years prior. So they did not have any children, and they did not have any family in Canada. So they were a fairly isolated couple. Several months prior to the killing, the victim's health began to decline. She was hospitalized for several ailments, including the onset of dementia. In a hospital admission note, the perpetrator had disclosed that he had plans for a double suicide if things got worse. He requested that the staff not tell anyone or write his comments in his wife's medical record. Because of this, the hospital staff made the couple an appointment with a geriatric mental health care clinic. The perpetrator indicated that he made the comments because he was under great stress and had been previously dependent on his wife and was not used to being in the caregiver role. During the evaluation with the follow-up appointment, the perpetrator was reported to be caring and concerned for his wife, but they concluded that he had little insight or awareness about her possible deterioration. He was felt to be at a high risk of caregiver burnout. As a result, a plan was suggested for increased community support, 24-hour support, and a follow-up by a social worker. A backup plan was suggested that both the victim and the perpetrator could go into long-term care if they found themselves in a situation where he could no longer care for her. The perpetrator was reluctant to ask for more help and indicated that he did not want increased resources. He said that he and his wife were both private individuals and didn't want more people in the home. Some friends and neighbors had reportedly noticed declines in the couple's health and the increasing stress that they had been facing, but they say that they did not see this coming, with the exception of one person who lived a fair distance away, who said that they feared something like this would happen because every time they talked to the perpetrator, he had indicated that he could not go on. A month prior to the deaths, the perpetrator visited a hospital emergency with dizziness and tightness in his chest, and he was diagnosed with stress and sent back home. About 4 days after the homicide-suicide, a social worker completed a 2-hour follow-up home visit to assess the victim's care needs because of her dementia. The social worker conducted an evaluation of the victim and spoke at length with the couple regarding the stress associated with caring for a loved one. There was no further mention of the double suicide that was mentioned in the previous hospital visit at this appointment, but the social worker was not aware of the previous suicidal comments and so did not know that she should probe around this issue. The social worker did not detect any signs of suicidal thoughts or depression during the visit and was going to recommend to the psychiatrist that there be no further intervention. The records also indicated, however, that the social worker felt that the couple could be at high risk by virtue of their age, their health, and family isolation, so there were some contradictions in the records. However, during the visit, the perpetrator consistently told the social worker that his stress level was fine and that they were managing well. He informed community care that he and his wife required no additional care from the organization. The perpetrator shot the victim a few days later and then called police to report the homicide. He then committed suicide by shooting himself. And as we can see on the bottom of the screen, that there were 4 risk factors in this case: prior threats to kill the victim, that was the reference to the double suicide, prior threats to commit suicide, depression on the part of the perpetrator, and access to or possession of firearms. So a number of recommendations came out of this case. The first was that all healthcare providers who work with elderly patients should be educated on the risk factors related to domestic violence and potential domestic homicides. Second, it was recommended that the Ministry of Health and Long-Term Care, in collaboration with the Ontario Hospital Association, should develop information materials on structured risk assessment and risk management strategies as part of a care plan to deal with domestic violence in the elder population, similar to their efforts on suicide prevention. A third related recommendation was that the accreditation process for Ontario hospitals should include policies and procedures directed toward the assessment and management of domestic violence in the elderly population, which should include red flagging potential high-risk cases with ongoing information sharing amongst multiple health professionals who are involved with the individuals who are experiencing the risk factors, and that so that an overall coordinated and integrated approach would be more forthcoming. So these three recommendations, obviously, having gone through the context of the case, arose out of the committee discussion that centered on the need to red flag high-risk cases so that no matter which healthcare provider was actually interacting with the couple at the time would be alerted to the double homicide comment, for example, in their future interactions, so that it would be able to probe or watch more closely whether or not these were still risk factors. In this case, there was already concern given that the perpetrator had made a suicidal threat, and they had already noted that there was potential caregiver burnout. The fact that he showed up in the hospital 3 weeks prior with before the murder with dizziness and chest pains, and there was still no indication about the previously noted concerns at that visit were also problematic. And so the sharing of information should be within the context of the circle of care provisions, in terms of everyone in the circle of care should be aware of some of the comments and the risk factors that others are noting. Generally, we also noted that physicians need express or implied consent before disclosing personal health information. However, they are entitled to assume that they have the patient's implied consent for the purposes of providing or assisting in providing health care, unless they've been explicitly told not to or that consent was withdrawn. This means that without reason to believe otherwise, physicians can share information with others involved within the patient's circle of care without asking for consent. So we also noted two other recommendations in this that arose from this case. The first is that the Ontario Women's Directorate should extend education efforts on domestic violence to ensure that the general public is aware of domestic violence in this population. And then also that the hospital and the community care access centers that provide care to victims and victims that may be in similar types of cases should also conduct internal reviews to determine what safeguards should be in place to prevent future similar deaths. So this murder-suicide obviously was involved an elder couple who appeared to be in it was a case that appeared after the fact, of course, which is often the case, to be predictable and preventable in light of the perpetrator's explicit threats in the context of multiple risk factors such as declining health, isolation, and a lack of family supports. And so there were many healthcare professionals in the hospital and in the community who were involved, but they lacked a structured risk assessment or information sharing mechanism that could have helped to flag the murder-suicide threat to those healthcare providers that came afterwards. And so there was a lack of coordination that may have prevented this death from occurring. So the second case example is also a homicide-suicide, and we'll see that most of them are, again, because they're the highest proportion of these types of cases, involved a 70-year-old victim by her 74-year-old perpetrator husband. They had been married for 42 years and had 4 children. This victim had no significant health issues, had been a stay-at-home mom all of her life, and was reportedly a private individual for whom English was a second language. The perpetrator was recently retired and struggling with low self-worth and low self-esteem because he was no longer active. The victim told family members that she feared he would harm himself, but expressed no fear for herself prior to the homicide-suicide. The perpetrator's increasing depression was compounded by some health issues and other external stressors that were occurring within his neighborhood. The family doctor had referred the perpetrator to a psychiatrist as the decline in mental health had been quite noticeable to him. So he was under psychiatric care for about 3 weeks prior to the killing due to anxiety, episodic panic attacks, and talk of suicide. The perpetrator's family became concerned when he attempted suicide 1 week prior. At that time, the victim had found him in the process of attempting to commit suicide by hanging himself with a belt, and she called her eldest son. The perpetrator was admitted involuntarily to the hospital under the Mental Health Act. And at the time of this admission, the victim disclosed to family members and to some of the hospital staff that the perpetrator had been suffering from depression and not sleeping well for about 2 years, but that he had asked her not to tell anybody. The perpetrator had also told the victim that his depression made him feel useless. And in part, his depression stemmed from his retirement. As one example, At one point, he needed to fix a leaky roof that they were experiencing in their own home. And he told the victim that if he had a gun, he would have ended it right there because he felt so useless that he couldn't fix his own roof. She admitted that she had become so concerned about him after that comment that she followed him around and was afraid to leave him alone. As a result of the hospital admission, the perpetrator was put back on antidepressants, and he participated in supportive psychotherapy and assessment interviews. His diagnosis was major depression resulting from retirement and other situational factors. He reportedly responded well to treatment while he was in the hospital. After about 4 days, the hospital felt that the perpetrator was ready for discharge as he was no longer seen as suicidal. At this time, the family expressed concerns and told the hospital staff that the perpetrator tended to hold his feelings in and requested an outpatient follow-up plan and an opportunity to return if necessary. The perpetrator kept insisting that he could manage on his own. Regardless, plans were made for him to see his own psychiatrist for follow-up, and the hospital provided him with his medication and a phone number to contact the outpatient crisis unit if needed. He agreed to make plans for his retirement and was planning on connecting with the local resources in his community. Once released from the hospital, the family, still concerned about his mental state, took turns staying with their parents at their home at night because they were fearing of what would happen if they had left them alone. On the day of the homicide-suicide, the family was not able to get in contact with the elderly couple, and so the police were notified. Police attended the residence and found the victim deceased on the floor at the base of the stairs. The victim had bruising and redness to her neck area, and the perpetrator was found on the floor of the basement with an electrical cord around his neck and a faint pulse. He was transported to the hospital where he died the next day. Autopsy results indicated that the victim had injuries that were consistent with defensive wounds and that she had been manually strangled. So here we see, consistent with the low number of risk factors that are common in cases involving elderly couples, that there was only 2 risk factors identified in this case: prior threats to commit suicide and depression on the part of the perpetrator, which included both noted by family and friends as well as professional diagnosis. So what recommendations were generated out of this case? The first one that was generated was that healthcare providers, police services, victim services, frontline services that are in contact with families or families who are experiencing situations with elderly couples should receive enhanced education and training about aging couples' increased risk of intimate partner homicide-suicide, particularly if they are experiencing declining or poor health and or some other major life change, such as retirement, which was the case here. And part of this enhanced education and training should emphasize the importance of inquiring about thoughts of homicide in addition to suicide when interacting with elder patients, because the tendency is to just ask about suicide, especially if these elder patients are known to be suffering from depression. And it also originated out of the need to interview couples separately, particularly when mental health issues may be present, because in this case, the couple was often seen by the doctor together, which is often the case, I think, as well with many elderly couples. Another recommendation that was generated was that healthcare providers should emphasize or discuss the importance of aftercare options or mechanisms for couples and work with their families to identify appropriate mechanisms when one partner is being treated for depression or other related mental health issues. And this is particularly important if there's evidence of suicidal ideation, which there was in this case, as well as previous suicide attempts, which were also present in this case. So again, we saw that this perpetrator was experiencing declining health, as well as situational and life event stressors, under psychiatric care for 3 weeks prior to the event, and he was being treated for depression. Attempted suicide 1 week prior, hospitalized, and then was released. And at the time, the family was then finding out about, and so were the healthcare providers, about how depressed he had been and the fact that he hadn't been sleeping well for a year. Now, in this case, it is not clear if the victim and the perpetrator were ever both interviewed separately by the treating psychiatrist at the time of the, if they were both interviewed by the treating psychiatrist at the time of the hospital admission. So in other words, did the psychiatrist talk to the wife as well? And despite the family's continuing concerns for the perpetrator's mental health and their efforts to stay with the victim, he was still able to commit the homicide-suicide as soon as they were left alone. So those two cases identify both the dominance of perpetrator suicide as well as the low number of risk factors. And in both these cases, it also supports the description of a large proportion of these cases where there is no known domestic violence between the couple. And it's not clear if this is due to the social isolation and vowing of privacy among these couples that may contribute to lower disclosure rates about previous domestic violence, or if there's actually no domestic violence that had occurred up to the homicide-suicide, which is also often a possibility. However, there are cases in which domestic violence does occur in the lifespan of elderly couples, and this violence occurs throughout much of the relationship, and so it isn't specific to the elder phase of their life. It has occurred throughout the couple's life, and this next case is an example of one of those. So as we can see, again, too, if you look at the bottom half of the screen, that this is a case that had 11 risk factors, so a high proportion of risk factors compared to the average in these cases. So this involved the homicide-suicide of a 69-year-old victim by her 69-year-old husband. They've been married for 51 years and had 2 children. This victim was experiencing chronic health and mobility issues and possible early dementia, although it hadn't been clearly diagnosed at that time. The retired perpetrator was reportedly in poor health, had no specific illnesses, though, that were identified, but was reportedly depressed and anxious, was on antidepressant and anti-anxiety medications, as well as pain, ulcer, and anti-inflammatory medications. It was reported that for most of their marriage, it appears the perpetrator controlled the victim's activities and would not allow her to contact her family. He controlled who she communicated with, who her friends were, and how the finances were distributed. The victim had reportedly told her family that the perpetrator physically abused her, and however, she was apparently afraid to contact authorities and did not have faith in them for various reasons. She was also concerned about how to raise her children without the financial support of her husband, which was offered up as one of the main reasons why she had never left her husband during the course of their abusive relationship. Near the time of the homicide-suicide, both children acknowledged the abuse the victim had experienced over the years by the perpetrator. Prior to the homicide-suicide, it was evident that the victim and the perpetrator felt that they were becoming a burden to their sons and to each other, and that they were losing the will to live. The sons were apparently aware that the parents were both depressed over their increasing physical and emotional issues. The critical events that led to the homicide-suicide occurred when the perpetrator called for an ambulance after the victim fell down the stairs and broke her ankle. While she was in the hospital, she told a social worker that the perpetrator had pushed her down the stairs. In response to this disclosure, the social worker provided emotional support and referrals and discussed a safety plan with the victim and her sons. So the victim decided upon release that she would stay with her son because when she was in the hospital, the perpetrator had also threatened her again. The victim's son reported the incident to police, and when the police questioned the victim, she indicated at that time that she had fallen down the stairs. So the initial police report noted the conflicting information, and no further action was taken at that time. Later, the police questioned the victim again about the incident, and this time she stated that the perpetrator had grabbed her hair and either let go of her or she had just fallen down the stairs. The victim told police that she was afraid of her husband and did not want to go home. Based on this information, the police sought an arrest warrant for the perpetrator for assault causing bodily harm. Throughout this period, the perpetrator was still trying to see the victim at their son's home, and he later did attend the police department after the warrant was served for his arrest, and he was released on an officer-in-charge undertaking and a promise to appear. The only conditions were that he notify the police of a change of address and to abstain from communicating directly or indirectly with the victim unless she initiated this communication herself. Eventually, these low conditions came to the attention of the police firearms registrar, and an application was brought to court to seek stricter conditions for the perpetrator and the surrender of firearms and his licenses within 7 days, not to be within 100 meters of any residence at which the victim was residing. The perpetrator's firearms were removed, and the victim, accompanied by a police officer, retrieved her property from their home. The victim reportedly felt that her sons, at one point, however, were being controlling, and she started to want to go back home and live with the perpetrator. She appeared to be getting more depressed about her health and not able to take care of herself or her husband. A victim services worker had spoke with the victim and was informed that the perpetrator was now living at the son's residence with the victim. The victim was now stating that the perpetrator's behavior on the day of the alleged assault that he was charged with had not been normal, and that she was now not concerned about the perpetrator assaulting her again. The victim services worker indicated that the presence of the perpetrator was a breach of his conditions and told the perpetrator to speak to his lawyer. She apparently then made a recommendation to the Crown Attorney's Office to vary the no contact order because the victim was now in voluntary contact with the perpetrator, but it's not known if this actually happened. Both the victim and the perpetrator reached the point where they were having a lot of trouble living in their son's home, and they felt that they were a burden. At one point, the son had heard a conversation between the victim and perpetrator where she said that she was a burden and didn't want to live anymore. On the day before the killing, both the victim and the perpetrator indicated they wanted to move back home to their own house. Their son moved them back into their residence later that afternoon. The next day, the perpetrator called his son and the police and said that he had killed the victim and was going to kill himself, that he was sick and finished with his life, and he was going to kill himself so nobody would be blamed. He told his son not to come to the house because he may be blamed for the homicide. The son also remembered the perpetrator saying that he and the victim had talked and they were both tired of living like this. When the police arrived at the scene, they were both found dead from gunshot wounds. The perpetrator had obtained an unregistered firearm that was used in the homicide-suicide. Over a 5-month period, this victim appeared to have gone from wanting to take action towards ending the domestic violence to resigning herself to her fate based on a lack of solutions she found acceptable within her family system and the community. There were several professionals, particularly within the policing and social service fields, who appeared quite diligent and thoughtful in reaching out to this family in an effort to address the issues of domestic violence. So again, there was a number of risk factors in this case compared to the typically lower number, and there was also some recommendations generated out of them. So we see the first is around making sure that frontline service providers or people who are providing services to the elderly are reminded of the resources that can provide valuable information about the identification and response to this type of abuse, such as Neighbours, Friends and Families, Ontario Senior Secretariat, and more resources on the Ontario Network for the Prevention of Elder Abuse. So there are resources that were identified in the recommendation. And here we noted that the victim in this case was an older woman who was more vulnerable due to the physical and mental health issues as well as limited mobility, meaning she more or less needed someone to take care of her. And she was allegedly subject not only to abuse by her husband, but by her own words to controlling behavior and conflicts over finances with her children. It was also recommended that victim services workers be reminded that they should immediately contact police when they become aware that conditions of an order have been breached, and consideration should also be given to establishing and or revising safety planning or risk management issues. And here we knew that the victim services worker was aware that the victim was in voluntary contact with the perpetrator contrary to the no contact order. We also recommended that police services be reminded that the conditions of release should clearly emphasize the non-discretionary nature of the no contact orders, and that victims may need to be reminded and advised of this as well, that it applies also to them not contacting the perpetrator or the alleged perpetrator. And then also to healthcare providers, when dealing with possible victims of domestic violence, healthcare providers are reminded of the need for a formalized risk assessment to guide interventions and prioritize planning. In this case, the perpetrator was ordered to stay away from the victim. However, just prior to the suicide, we saw that they moved back in together, and family members knew the couple were back together and had assisted with the move. And potentially, if a formalized risk assessment or a detailed risk assessment had been done at that time, it was potentially that some of these risk factors may have been noted more clearly. So the final case involves a homicide-suicide again of an 83-year-old victim by her 85-year-old husband. They had been married for 55 years and had no children. She had health issues, but they were related to her heart, but reportedly not significant because it was indicated that she was still a very active woman, had fun with friends, and was very social. In contrast, the perpetrator was retired and had been diagnosed with depression about 3 years prior to the homicide-suicide, but by his family physician. The physician had known the couple for 10 years, and during this time, and this goes back to the previous recommendation, the couple attended their appointments together and were never interviewed independently of one another when they did visit their family physician. The last time the perpetrator was seen by his family doctor was the day before the homicide, and the physician at that time felt that he was not suicidal. And the but there was no documentation of any questions related to homicidal thoughts. The perpetrator had been experiencing insomnia for many months, and many people knew about his sleep issues. At the time of the homicide, the perpetrator was on multiple medications, including for anxiety and depression, and from the records reviewed, it does not appear that the perpetrator was referred for additional psychiatric services, despite this. The perpetrator's depression seemed to be worsening in the week prior to the homicide. He had been receiving acupuncture, and the therapist stated that his anxiety and insomnia was increasing, and he was concerned because his wife had a heart problem and had declined to have surgery. Despite the problems the perpetrator was experiencing, the couple was described by many friends, relatives, and acquaintances as loving and, quote, joined at the hip. They did most activities together, including playing cards, traveling, bingo, cribbage, and attending church. And there was no documented history of domestic violence or other criminal behavior. There were also no financial concerns identified. The perpetrator stabbed himself immediately following the death of his wife at his hands, but he survived for several weeks, eventually succumbing to complications and pneumonia. As the perpetrator was in custody at the time of his death, a mandatory coroner's inquest was conducted in December 2008, but there was no recommendations arising from this inquest. So 2 recommendations arose out of this case, some of them repeating earlier ones that we had related to elderly couples, and that's healthcare providers are reminded to inquire about suicide and homicide together when interacting with elderly couples suffering from depression and predominantly elderly males. And then second, healthcare providers are encouraged to interview couples separately, particularly when mental health issues may be present. So that provides, so I started out with the broader context, and then we went down to some more recent trends and some risk factors, and then provided 4 case examples of what are typical lethal violence and intimate partner homicide, suicide involving elder couples. So where do we go from here? What do we know then about elder couples at risk? And just a bit of a recap before we, answer the question of where do we go here. We know that for elder couples, there's a greater sense of isolation for both the victims and the perpetrators. And this is often exacerbated among some populations in particular. And so whether it be that English is a second language, that they're living in rural, remote, and northern areas, whether it's because they don't have children and social networks that they can draw from, isolation and social isolation is a significant factor in thinking about how to prevent these cases. Separation, often highlighted as a key risk factor more commonly for domestic homicide and domestic homicide suicide, is less often a risk factor for older women who are still in relationships with perpetrators and may want to remain in those relationships or do not know how to exit those relationships. And so separation, doesn't play as much of a role here as it does in some other cases. The greater likelihood of mental health issues is also quite pertinent, particularly depression among the perpetrators. It's been documented consistently across a number of cases, and in many cases has been professionally diagnosed, as opposed to just noted by the family and friends, largely following the homicide. Victims' physical and or cognitive impairments may also play a role, but we saw in some of the case studies that this wasn't always the case. In many cases, while there was health conditions that may be expected at particular life stages, they were not impeding the desire of some of the victims to continue to live and enjoy life. But the potential role of caregiver burnout, particularly if it's a male caregiver, also played itself quite predominantly in some of these cases and in the literature as well. And this is largely explained as being due to the fact that males of this generation are often not used to being in the caregiver role. And this role reversal is quite significantly a stressor for them, particularly when they have a wife or a partner who is suffering ill health. And then finally, a reluctance to include authorities or rely on available resources. And that could be because of the privacy, more conservative attitudes. It's not quite clear where that comes from, but there is a greater reluctance among these individuals. So where do we go from here? Just some thoughts that I'm throwing out from the literature, from our case reviews, from some of my own thoughts about this. And at the bottom of the screen, I put others in a question mark because I'd love to hear your thoughts on some of this. But obviously, given the greater and the growing We need more training for professionals so that they have more informed responses to domestic violence involving elderly couples. More attention to caregiver burnout, particularly when a male is in the caregiver role and is depressed and possibly suicidal. More coordination among services that are dealing with elder populations, because often they have a large circle of service providers because of their growing needs. And then finally, recognition that separation is less common as a risk factor, so not focusing on that when interacting with women who are experiencing violence by partners that they will not or maybe cannot leave. So those are just some thoughts, and I will end it here to make sure we have some time for questions. And I would be happy to get any feedback or thoughts from anyone either right now or at my email address at a later point. So thank you very much.
Thank you, Myrna. I know that Monita, one of my colleagues, is going to present the questions that were typed into the chat box. And please feel free, attendees, to type your questions in and we will read them aloud and ask Myrna if she's able to provide some answers for us.
Okay, so my first question was mental illness broken down into forms of illnesses like depression?
Yes, so when we do the domestic homicide death reviews, we do note where possible what the mental health issues were. So that's not always possible to do because sometimes the mental illness has not been officially diagnosed, so we don't have an official diagnosis. But we do particularly try to identify when it has been depression, which is often the most common mental health factor. Right now, we haven't sort of dug down into the specific mental health issues, but we do have that information in the database where we are able to get it from the files. Yes.
Okay. At what stage are the recommendations being implemented?
I think that's a very good question. So currently, there is no mandate for recommendations to be implemented. So at this point, the Domestic Violence Death Review Committee makes recommendations, and we've recently made some effort to follow up to see at what stage those recommendations may or may not be implemented. But there's no consistent mechanism in place to do that. Some countries that have domestic violence death review committees have legislated that responses are required from the agencies that recommendations have been made to, but that's not the situation in Ontario. So it's not, we don't have good and consistent knowledge about the implementation of our recommendations, which I think is a key issue that should be addressed in the future, whether it be through legislation or policy mandate.
Okay, the other question is, whose role is it to follow up on recommendations?
The role to follow up, there is no identified role. So right now, because we are our mandate includes making recommendations only, and we have no power to mandate that those recommendations are implemented. It's left to the agencies who have been identified as the individuals that would be the most expedient to take on that recommendation. So there is no structure in place to actually monitor this, which again is a key concern of mine and one that I'm hoping that will be corrected in the future, but there is no one individual that will follow this up. So some of my other research that's related to this work actually looks at recommendations that have come out from domestic violence death review committees, because in part we don't actually even have a good understanding of the content of some of these recommendations. So some of my team here at the center have been looking at Canada's recommendations as well as the 4 other countries. And so we've been coding close to 5,000 recommendations that have made internationally to see where the commonalities are. But again, that just captures what's being recommended. We don't have a system in place to be sure that they are being implemented. And here, in defense of what's going on in Ontario, this is a common theme among death reviews in the countries that they're operating in, which is a real issue and a real concern.
We don't have any more questions, so we are going to invite the participants to share or type in the questions in the chat box so that Myrna can answer them for us.
And so at this point, I think it would be great to actually hear from folks who had some thoughts potentially as I was going through the case examples, some other interventions or points of prevention that they had thought of when they were listening to the more detailed cases, if they had any thoughts on that.
Okay, the hospital recommendations for physicians to share client information is not implemented. Can you make a comment on that?
So is the question whether or not it has been implemented?
The question is, I guess it's a statement. The hospital recommendations for physicians to share client information is not implemented.
Just let me find that. As far as I know, so there's a policy, so that particular recommendation, I don't know if our recommendation has been implemented or not, but there is apparently a policy already in place around the physicians, when physicians are entitled to assume that they have patients' implied consent. So I can send the link to that policy website, and the individual can take a look at that if they wish. I'm not sure if the actual recommendation that we made has been implemented.
So she said yes, please send us the link.
Okay. I will do that.
Any other questions? Have you examined dementia-related homicides?
Yeah, so this, okay, so, and this is growing, thank you for this question. This is a growing sort of body in the work around elder abuse and around intimate partner homicide and intimate partner homicide suicide. And we are able to document dementia when it occurs in the cases that we're reviewing. And in the larger literature, it's become more clearly a focus because of concerns around aging population and the growing individuals that have dementia. What I think is interesting to note here is there is care issues among some of the victims with respect to them having dementia and the caregiver burnout on the part of the male caregiver. What is new, like it's a new focus, but what seems to be coming out is that fewer of these cases arise because of the male themselves suffering dementia. So it's more often in the caregiver role than actually the male experiencing the dementia himself. When we're talking about the intimate partner homicide suicide. But again, this is something that's just started to really come out in the literature. And we, because of the small number of cases that we review in Ontario, and then the smaller number of cases that involved elder abuse, I don't think elder couples, we couldn't make any conclusive statement about this, but dementia has come out as something that occurs with some regularity in the cases among the victims, but not necessarily among the perpetrators.
Any other questions? So Sheila, I don't see any more questions. Can you, I'll defer to Sheila, my colleague.
Wonderful. Thanks. I'd like to give a big thank you to Dr. Myrna Dawson for taking the time to pull together and share this really important information with us today. We're hoping that our efforts are working towards some of those recommendations in terms of educating and creating awareness. She's really helped us to develop that increased awareness of the issues surrounding domestic violence in later life and the reality, unfortunately, of homicide suicides in the older population. I'd also like to thank Linda Baker for inviting past, current, and I know for sure future collaboration to enhance our understanding of domestic violence against older women. We have a great, strong collaboration. And I'm going to take the last few minutes to tell you a little bit about Elder Abuse Ontario and highlight a resource that you may find useful, especially after today's learnings. Basically, Elder Abuse Ontario has been around since 1990, and our mission is to create an Ontario where all seniors are free from abuse. And we do that through awareness activities, education in communities, training, collaboration, and service coordination, working with local elder abuse networks, as well as advocacy. And it's our role to oversee the implementation of the Ontario strategy to combat elder abuse. And I hope that part of what we've done today and this knowledge exchange certainly fits within the efforts to implement Ontario strategy to combat elder abuse. Myrna, if you take it to the next slide for me. And here is our, this slide went a little wonky, but this is our four major priorities. And today we would fit under training and public awareness, we hope. Next slide, please. So what I would really like to share with you is a toolkit that's fairly recent. It's from 2017, and it's our safety planning toolkit for older adults. It is a resource that can support intervention and prevention. And both the introductory webinar and the toolkit are available as free downloads from our website. And I have included the link here on this slide. So I really encourage folks to take a look at this. It is specifically for older adults, and there haven't been many tools aimed at that population in terms of safety planning. Next slide, please. I do want to give credit to our collaborators on this tool. METRAC and the Canadian Law Foundation supported elder abuse in developing this tool. Next slide. I do also want to encourage folks to visit our website, because this tool that I'm highlighting is just one of the many valuable resources we have available. So please check us out. If you go on to our training and our resources, you'll find wonderful webinars that have been recorded on all types of different elder abuse information, as well as download free modules on different types of elder abuse. So wonderful free resources for you. Next slide. So in closing, I'd like to thank my Elder Abuse Ontario colleagues, Monita and Stephanie, who greatly assisted with the planning and facilitation of today's webinar. They were mostly quiet. Monita helped with the questions, but we want you to be able to reach out to us. So our contact information is listed here, and you can get it from our website too. So please, if you have any questions after the session or comments, we would love to hear from you. And lastly, I'd like to thank all of you who attended and participated today. It is our hope that you now have an increased awareness and understanding of domestic violence in later life, and especially the possibilities for intervention. So thank you for taking the time to join us. And that's a wrap.
Also, if you could please fill out the evaluation that will be sent to you, that would be fantastic. Thank you.
Thank you, Monita. Thanks.
Thank you.
Thank you all.
Monita?